Forceps. So what do I do with the forceps? Grab the baby's head and start pulling. Because you need to get the kid out. Why? Delivery starts when massive changes are going on in the fetus, the communication between the fetus and the mother's brain, and then the communication between the mother's brain and the placenta. Typically, once delivery starts, the placenta starts to, the connections between the placenta and the mother start to let go, which means you lose blood supply. Oh, I have this fetus, soon to be a baby, on the inside. I cut back the blood supply. Oh, what can't the baby do? Breathe. Oh, we have a problem. Instruments to assist with birth, or a C-section. The contractions have died down so much that no pushing happens anymore, no contractions. Time to cut, take out. A longer delivery, typically the latter stages of labor tend to be lengthened. So, I don't know. I don't think there is what we can call a typical delivery. I had a colleague who was absolutely incensed with her sister because it was one of those things where she basically, from the time her water broke to the time she got to the hospital, she had a baby. It was like labor lasted, I don't know, an hour and 45 minutes. So, yeah. Increased need of oxytocin. Oxytocin. What do you know about oxytocin? Anything? It helps, contractions, yeah.
Stimulates lactate production in the mammary gland.
It stimulates the release of milk, yeah. And it's involved with uterine contractions. Tocin is artificial oxytocin. When you hear about someone having induced labor, they're doing a tocin drip. IV goes in, drip starts, and typically soon after it enters, you start to see, on a monitor at least, mild contractions. Some women this works wonderfully, some women it doesn't work well at all. But yeah. Low blood pressure. Injections into the epidural space frequently result in a drop in blood pressure. Drop in blood pressure is bad for both mom and fetus. So you have to kind of keep an eye on this. I don't understand the relationship with increased muscle weakness after birth. So I'll just tell you it's a complexing side effect. Increased risk of fluid retention has to do with the fact that you're putting the anesthesia in directly into the epidural space. And once again, I don't completely understand the increased risk in fever. But these are all kind of, the why yes, why no. So you now have a little more of an informed view when it comes to epidural anesthesia during delivery. Yeah.
I think it depends on the person, though. It
Absolutely. Oh, yeah.
Everybody. No.
Well, this applies to everybody. This does. Okay? Once again, increased risk. Increased. Your risk might be 2%, somebody else's risk might be 70%. So it varies from person to person. It's just if you are going to get an epidural during delivery, this is the list of things you should know about. That's all. That's what I'm saying. None of it might apply to you. You might just, spit out a kid in like 20 minutes. Bang. Gone. And stuff. But you can typically expect some of these complications. Most women will have some complications involved. And all the advantages. Even though some women don't get that much pain relief. So it is variable.
It was fine for me.
It works, and that's great. That's, you know, and different people will, and we can actually say, and I can actually use women in this case. Different women will have different opinions on this. You know, there are women that get the epidural and then need a C-section. So, highly variable. All right. Well, so let's keep looking at stuff with your cord. Okay? Cervical cord here. It's interesting. We're gonna be looking at the various nerve plexes in the very near future. But this is the cervical plexus. Cervical plexus is kind of interesting. You won't have a lot to really learn about the cervical plexus because this textbook tends to really short the cervical plexus. But here we have the cervical roots, okay? So C4 nerve, C5 nerve, 6 nerve, C7 nerve. When we talk about a nerve plexus, we always refer to it with relationship to the nerve roots. So C4 through 7 here, parts of the cervical plexus. You should know the roots for the plexes, okay? When we get low in the lumbar area here, we have the lumbosacral plexus. Some textbooks take a very different approach to this. Different textbooks have different approaches. Some textbooks we have the lumbar plexus and the sacral plexus. Some textbooks tie it all together. Just be aware of that. So typically, when we talk about the lumbar plexus, we're talking about L3 through S1. The actual cervical plexus as well will include some other sacral plexus will include some other sacral roots. So just kind of tweaking your appetite for nerve plexes. Nerve plexes are a bitch. I'm going to tell you that right now. They're tough, they're complicated, they're difficult to understand, but you still have to do it. So, you have spinal nerves. Your spinal nerves come out and they exit in many different ways. And you can have problems. You can have two sets of problems. Number one, you can have a pinched nerve. Pinched nerves and herniations, by the way, happen, you know, from your shoulders on down in general. With a pinched nerve, something has happened that typically will put pressure on a single nerve root. So that's really important. Typically with a pinched nerve, you might have a misalignment of something. You might have muscle tightness on one side that causes an imbalance in the way your vertebral column lines up. On occasion, you can have an imbalance in hip muscles, to where one set of hip muscles, your lateral hip muscles, are disproportionately developed versus your medial hip muscles, in which case it'll cause a pull on the hip and it'll cause nerves to be pinched. So this is fairly simple to deal with. Most of the time with a pinched nerve, you have to learn, you'll be teaching patients how to do things so that they stretch muscles out, so that you do exercises to get the muscle groups in balance, so that you don't put the pressures on those particular nerves. Are we okay with that? All right. Herniation, on the other hand, is a little more complicated. Herniation involves a problem with the vertebral disc. Disc problem. Now you remember that disc had that pulpus nucleosus, the nuclear goo on the inside. And that the disc itself is made up mostly of fibrous connective tissue. So we have some form of trauma, some form of problem that causes that fibrous connective tissue to start to bulge. As the shape changes, the nuclear pulp pushes out. It can actually start to push out from the center portion of the disc to where it extrudes. And they're showing you 3 different types of hernias here. Okay? This is a far lateral hernia. This is a posterolateral. It's really between the two of those, so it'd be here. And this is a central herniation. They each have different outcomes. With herniated discs, typically a good strategy to start with in taking care of the herniated disc usually is physical therapy. If you do physical therapy, you can get this to resolve and the nuclear pulp to go back into the disc. It can literally be pulled back in. What have we avoided? Surgical intervention. Anytime you can use adaptive behavior or physical therapy, I know that some of you that might be a dirty word, but it's still necessary, to avoid surgery, that's good. Just like your brain, you don't want to start cutting in around your spinal cord. Every time you cut into the area around your cord, you're introducing scar tissue. So that's always bad. Okay. So, what's the difference between these different types of hernias? So here's your disc. Here's the central herniation. Okay? Posterolateral and lateral. I put 5 herniations into the one. That would never happen. This person, they're toast. All right? It's not going to happen. Now, let's start with the lateral herniation. Typically, the lateral herniation is going to affect one spinal root. Well, that's good. As a matter of fact, that can almost be confused with a pinched nerve. And you know how sometimes people are diagnosed with a pinched nerve, then they do imaging and they say, oh, you've got a herniated disc. Chances are that's a problem. It's a lateral herniation. The lateral herniations, doesn't matter where you go, can only affect one nerve root. Are we okay with that? All right. The posterolateral, here it is. This posterolateral one here is clearly affecting this, but it's also pushing on that. Multiple nerve roots on one side. Unilateral, multiple roots. Do you see how that would work? All right. And then we have the central one here. Here it is. Here it is. What's that pushing on? A lot. Bilateral, multiple roots.